Hello, I'm Rose Madden-Baer, and I'm going to talk a little about some of the acute, post-acute, and community-based models of population health we're doing at VNSNY. Just a little about VNSNY. We believe we are the nation's largest not-for-profit home health organization. And on any given day, we touch about 70,000 lives through our enterprise healthcare delivery system and health plan. And we have a home health agency, hospice, palliative care, Medicare Advantage, managed long-term care, private duty, a very large paraprofessional workforce, and have embarked on some additional models of care as well. We believe at VNSNY that we have a dual imperative not to transform ourselves from not only being the most excellent provider of home health services, but also to use our care coordination and care management expertise and to develop what we call centers of excellence around care coordination and to provide for new care model opportunities across as new payment structures develop and as new models of care develop, and to use that care coordination expertise in sort of serving as a laboratory for community-based healthcare organizations. Our vision, to that end, we believe we are striving to be the significant best-in-class, not-for-profit, community-based integrated delivery system. Notice I did not say home health because we believe we are so much more than that, providing superior care coordination and care management across to all populations across a broad regional footprint. And just so you know, within Visiting Nurse Service of New York, our patients are cradle to grave. Actually, even before cradle, because we have a nurse-family partnership evidence-based model that we serve young mothers at the point of pregnancy to 2 years thereafter. It's an evidence-based program. Our population care model, care coordination model, we have a platform, and within the various models that we deliver in both our bundles, our delegated care management opportunities, and in our various population health strategies and contracts we use pretty much the same population health platform and then sort of match it up with whatever it is that the customer is asking for or brings to the table as well. So we have predictive analytics. We have a robust research center that helps us with development of a predictive model algorithm. We stratify individuals into low, rising, and high-risk buckets dependent upon their risk score, whether it be a risk for hospitalization score or a risk for care management or specific care coordination score. Once we stratify those individuals, dependent upon the product, we use a series of evidence-based tools, and I'll talk a little about what those look like as we go through the specific programs. Our evidence-based tools, we use a patient activation measure, and we actually measure changes in activation scores over time while they're on the program. We also use a Mariski medication adherence scale and measure changes in medication adherence scores because we have specific interventions around medication adherence. We also train to behavior activation, motivational interviewing. We use evidence-based depression screens as well. We developed a person-centered goals and care plan. We call it our OGIs, opportunities, goals, and interventions. And we actually document in our population health models in a care management system. not a home health care documentation system. It is a care management system which employs a health risk assessment that drives the predictive analytics to the risk score, and then we have scripted interventions around whatever particular risk that person is at. We have an assessment, a robust sort of catalog of assessments that we do, comprehensive health risk assessments. As you know, in the state of New York, there's a uniform assessment. We've moved to a uniform assessment that is also available in our care management system. And we also, we use in our bundle, obviously, the OASIS, but we rerun the OASIS, the predictive analytics at start of care and discharge for the bundle. Our assessments are performed by RNs. They are trained as population care coordinators. They go through a 12-week intensive care coordination program through Duke University School of Nursing. They are awarded master's credits for it, and they go through modules such as care transitions, evidence-based practices, social determinants of health, issues around health literacy, and socio-demographics, how to care manage individuals, both from a medical model, but beyond a biobehavioral model, and actually looking at social determinants of health. We provide health coaches, and Robin would be very happy to hear that they are paraprofessionals that are offered a career ladder that goes through Eric Coleman's Transitions of Care, and they are awarded a certification as a health coach. And we also collaborate with other primary care and other providers. We have a home visiting NP practice, physician and NP practice, and we utilize that in some of our care coordination models. This is basically what our population care coordination team looks like. As I stated, they're anchored by an RN population care coordinator. Our hospital-based RN liaisons in some of our care transitions models with health plans, they have actually transformed into what we call transitional care coordinators. And they meet the individuals at the bedside in the hospital, and then do a comprehensive risk assessment, go through the 4 pillars, med-rec, red flags, securing a PCP appointment, and understanding your discharge instructions. We also provide for a social worker in some of the models around social determinants of health, around health disparity, demographic issues, and around behavioral health interventions. The health coach has a dual purpose, not only from coaching and navigating, but also in some of the very high-risk individuals will actually go with the person to their first PCP appointment and translate in a health literate manner. They often come from the same communities, they speak the same languages, and have the same demographic to these individuals we're working with. A shout out to Sutter Health, who has provided us through a collaboration with stoplight cards that we use. The health coaches use them routinely in sort of translating medical terminology into real person language. Our population health applications at VNSNY, we have 2 Medicare sanctioned bundle payment demonstrations. I believe we are one of the few organizations in the nation that do a post-acute Model 3, bundle payment Model 3. We also are doing a bundle payment Model 2 with an academic medical center in New York City. We are also embarking on a hospital at home with a large academic medical center in New York City as well. We are doing delegated specific care management for health plans. And what I mean by that, they have delegated disease management, care management to us. One is an insurance broker for union health plans that are trying to manage their pre-diabetics and their diabetic populations. So we have a whole list of strategies we're doing, and we're actually using the problem areas in diabetes survey to see around person-centered outcomes, improvement in person-centered outcomes. We have a post-hospitalization transitional care model with ACOs and health plans in terms of embedding population care coordinators within the medical groups and using them remotely for transitional care. We're doing a transitional care with a large health plan for 30 days. And in the bundle, we are doing a 60-day and a 90-day as well. We were awarded through a contract with the Office of the Department of Health, Office of Mental Health, a contract to manage coastal communities post-Hurricane Sandy, where we're doing health and wellness, behavioral health support for post-traumatic stress disorder, and health and wellness, reconnection with their primary care, sort of reconnecting families. And we were awarded $1.6 million by the American Red Cross to manage these coastal communities with our population health program. As you know, New York State is right in the heels of DSRIP, the Delivery System Reform Incentive Program. It has absolutely taken over the state of New York in terms of strategies around care coordination, social determinants of health, managing duals, Medicaid populations, behavioral health. And we've been asked to partner with approximately 11 to date performing provider systems for our population health and care coordination expertise. And last but not least, we provide care coordination and are the largest managed long-term care plan in New York State. Some success factors and challenges: the use of evidence-based tools. Both our care coordination interventions, targeted and assessment tools are all around the evidence base. Our partnership with a leading academic institution to train our care coordinators. We were awarded a $500,000 grant from the Workforce Retraining by the State of New York Department of Health to train more population care coordinators, and another $500,000 to continue our training for health coaches and provide this career ladder for paraprofessionals. Our stratification driven shows that we use a dose mix of interventions. It's not an all-comer strategy. Dependent upon what risk level they are in, they either get a combination of certain disciplines, and it's a dosed mix. Challenges: reimbursement model, changing the perception of VNSNY as more than just a home health agency, that we are transforming into new and transformative care models, our own internal culture change, and of course, data capture. Thank you.